All right, so again, going back to how these transmembrane electrical currents will give rise to an extracellular field potential here. Take this example here. As I was saying, when electrode superficially towards the superficial layers of the cortex, it looks like the current is going away from the electrode, which by convention is called a sink, will be negative in polarity, and the electrode deeper will be positive. Now, obviously, you don't have, unless you have a depth electrode inside the brain, which you guys want to do. But this is just to explain how an electrical dipole is created in the extracellular field, which gives rise to the EEG. So this is the sink, this is the source. Now, this is not a physical thing, actually, it's a mathematical concept. It's just called an electrical dipole created by the differences in polarity in the superficial and deeper layers. So it looks like this. So this is the biological basis of all EEG. EEG is essentially extracellular field potential recordings, which are all biological dipoles. However, because one of the poles is deeper inside, you only get to the electrodes are usually only able to see one pole, which is the one which is superficial. And depending upon if it's an excitatory postsynaptic potential or inhibitory postsynaptic potential, this polarity will change. For example, this example that I'm showing you is obviously an EPSP. As you can see, the surface is more negative. But if I were to make an inhibitory postsynaptic potential, it'll be exact opposite in polarity. Now, this is the polarity convention. This is something probably very important to remember. In EEG, and again, this is totally conventional. If you connect electrode A to electrode B, in grid 1 to grid 2, if the wave is downward deflection like this, all that means is that electrode A is either more positive than B or B is more negative than A. Waves are never positive or negative. A lot of people refer to EEG waves as this is a positive wave, this is a negative wave. That's incorrect. Wave is not positive or negative. Wave is simply upward or downward, okay? And it's the electrode, which is either relatively more positive or relatively more negative. The easy way to remember it is, whatever electrode is in grid 1, you place it here, and grid 2, you place it here. The electrode that is at the mouth of the wave is more positive, and the electrode that's going to sit at the peak of the wave is going to be more negative. Now, there's always two solutions to this, and the reason for that is that for majority of the EEG waves, we do not know the polarity of the generator. So each one of them is a potential solution if you're trying to localize where this wave is coming from. And I'll show you an example here. For example, now this is the second example here. A to B, now it's an upward deflection, correct? So A is sitting on top and B is sitting at the bottom. Now, A is either more negative than B or B is more positive than A, okay? Now, for example, if you take this hypothetical scheme, this is the skin, the soft tissue, and this is the surface of the brain, the sulci and the gyri. Let's assume for a second, this crown of this gyrus has dipoles oriented like this, with predominant negativity facing the superior superficially and positivity facing deep. And let's say you have 3 electrodes sitting on the surface like this. Now, as I just told you, electrodes sitting on the surface are usually blind to the deeper pole. So if you just ignore this one for now, they're all looking at this negativity, but at different angles. So if you look at A is looking at it like this, B is looking at it with a wider angle, and C is also looking at it with a smaller angle. The wider angle that the electrode has towards the generator of the potential, the bigger will be the potential. So if I ask you, if you connect A to B, do you think it will be a downward deflection or upward deflection? A to B, which one is more negative between A and B? B would be more negative because it is looking at the negativity with a larger angle. Can you see that, right? So if I connect A to B, B is more negative. Would it be a downward deflection or upward deflection? It'll be downward, right? Because I said B would have to sit at the peak right here, okay? So when you have a wave like this, B will sit here and A will sit here. So B has to be more negative than A. Here, I'm already telling you the polarity of the generator. I'm telling you B is more negative, okay? Now, if I connect B to C like this, what do you think? Up or down? It'll be up, right? Because C is essentially the same as A. They have a similar angle of looking at this negativity. B is still more negative. So this is going to be an upward deflection because now I moved B into grid 1. So it sounds very simple, but this is the entire basis of EEG. The polarity convention is very important. Depending upon which grid you move the electrode in, that is what's going to determine the polarity of the wave, the deflection of the wave, and the polarity of the electrode generator. So something important to remember. Now let's assume for a second, I have made an EEG montage like this, where I'm connecting each of these electrodes to a relatively indifferent reference. And for your purposes, let's assume the reference is 0. Now, what would be the deflection A to reference? Up or down? Reference is 0. So it's negative, isn't it? So it has to be up because A would have to be sitting here. Because reference is 0. So compared to reference, A is still more negative, so it'll be downward deflection. Upward deflection. Does it make sense? What about B to reference? B is still more negative than reference. All of them are more negative than reference because reference is 0. But the B to reference deflection will be larger because B is a larger negativity. Does it make sense? Yeah. And C to reference will be the same as A to reference, okay? So this is the principle of volume conduction. What that means is that when you have a cerebral source of EEG, when a wave is being recorded from a cerebral source, the electrical field and the electrical potentials are conducted across the entire volume of the head. And for practical purposes, we assume that the head, including the skull, soft tissue, and the brain, is a homogeneous volume conductor. The example I give to the course participants is we all record EKG all the time, right? You have the limb leads and the precordial leads, right? You have a limb lead on the left wrist. How does it pick up your QRS? The heart is in the chest. It's not something that's propagating into your arm. It's not a propagating action, but how does it pick it up? It's volume conduction. Because electrical charges and dipoles do not care about anatomical boundaries. They care about if the volume in which you have placed them is a conductive volume or not. And human body is a conductive volume, okay? So even the heart is in the chest, obviously, but you can record the QRS from the wrist. It's not something that is going into the wrist. It's not a propagating action potential. It is at the same time. It's the concept of electrical field, just like you have the gravitational field, okay? It's a similar concept, where a charge in one space can affect a charge totally distant without traveling, right? This is a concept of electrical field. This is the basis of volume conduction, which is the basis of EEG. Now, I'm going to give you one pointer here. If you are ever reading an EEG as part of your sleep study or in addition, and you see an electrical potential, and you're not sure what it is, but you localize it, and you come to the conclusion that it is only localized to one electrode of all the electrodes that you have on the scalp, that is very likely an artifact, okay? Unless proven otherwise. With an intact head and an intact brain, cerebral generated waves should not localize to just one electrode because that is a violation of volume conduction. When you distribute it well and you localize the waveform, you should see a reflection in more than one electrode, okay? There's an exception to this rule, and that is when patients have skull defects, for example, craniotomies, because it is the bone which is the biggest impediment to the EEG potential being reported on the scalp. When you create a hole in the bone, you create a shunt. So you can have a cerebral source recorded at one electrode only, but that is an exception, not the rule. Okay. Now, this is what is called the 1020 International System. This is how electrodes are placed everywhere in the world. And the 1020 is basically the distance. For example, if you see here from the nasion to the first electrode, 10% of this entire distance, okay? And then the distance between the electrodes is 20% each, okay? Now, the reason we follow the system is so that you can reproduce results across different countries, different settings. Everywhere in the world, this is the system that is followed. And this is determined by the International Federation of Clinical Neurophysiology. So no matter where you do the EEG, the technologist that is placing the electrodes is going to take certain basic measurements first. They're going to measure this distance all the way from the nasion to the inion, and then they're going to measure what is 10%, what is 20%, and they're going to place electrodes accordingly. Okay, this is what allows for your results to be, you can reproduce them across different centers. Okay, now the convention here is odd numbered electrodes are on the left side of the head, and even numbered electrodes are on the right side of the head. Okay, so FP1 loosely stands for frontal polar. So as you can see, it's very much towards the front, right over your forehead. It's usually placed right here. So FP1 will be on the left side, FP2 will be on the right side. And then you have F3, C3, P3, which are parasagittal, right across the midline. And F7, this is old terminology. This is also called T7 and P7. Some people call it T3 and T5. As you can see, it is more over the temporal region, okay? So the reason these electrodes are placed in this manner is so that you are able to look at all the different areas of the brain, okay? And then you have these midline electrodes. This is what sleep people record, mostly from FZ, CZ, PZ. Most of the sleep grapho elements that you're gonna see tend to be maximally localized to these midline areas, whatever sleep graph elements you're gonna be looking at. So as part of many sleep studies, you might not have the full 16 or 18 channel EEG, you might just have 5 channels, and they are usually created by combining these 3 or 4 electrodes in the midline, okay? If you have any questions, just stop me, okay? So just to cover some basic terminology. That's going to restart.
Oh, no.
Well, I think just the PowerPoint is first. I hope the Zoom is still working.
None of the outlets are working either, so the computer's out here.
Let me,
We're still on Zoom, but.
yeah, I figured. I think it's just the PowerPoint slide that crashed.
Computer is on. I think it probably needs an extension. They'll try restarting again, clear out the memory again.
All right. So now, just to show you, this is a hypothetical placement of electrodes. This is not how electrodes are actually placed, but I'm just showing you this hypothetical scheme to go over some basic terminology, which if you read a lot of EEGs or sleep-related neurophysiology, you have to familiarize yourself with. For example, let's say you have 3 electrodes here, A, B, C. This is roughly where you're going to place FZ, CZ, and PZ, the midline electrodes. And let's say this is this random electrode on the head, which is a reference. And this is what's called a jack box or a head box. This is where the wires go into when the tech is placing them. Now, there's going to be 2 or 3 terms they're going to be using a lot. What is called a montage. Montage is basically just a collection of different chains. Now, but the first term to understand is what is a channel? That's the simplest thing to understand. A channel is one electrode connected to the other. That's it. For example, here, A to B, that's one channel. Okay. Now, once you make a collection of channels in a certain manner, that is what is called a chain. A single chain in EEG is something that is common. There has to be some sort of connection between the different electrodes. For example, if you look at this here, I've connected A to B and then B to C. So they're connected via B. I just move electrode B into grid 1 in the second channel. All right, this is a chain. And this is an example of what is called a bipolar chain. So a bipolar chain is when you take electrode in grid 2 and then you move it to grid 1. And you will do the same. So if you want to make it extend it more, if you have more electrodes, you take C to D, D to E, so on and so forth until it ends. Okay. This is an example of bipolar chain. So if you have a montage of different chains and they're all bipolar, that'll be a bipolar montage. I'll show you some examples. Then you have what is called a referential chain or referential montage. What that is you have electrodes that are all connected to a common reference, okay? So every electrode, you can take 16 electrodes and connect all of them to a common reference. That'll be one chain, referential chain, okay? This is an example of what a head box or a jack box looks like. As you can see, when the tech is placing the electrodes, this has kind of like a cartoon of the head, and they know exactly where to place which wire. This prevents them from connecting, for example, F7 to FB1 or F3, so they don't know exactly what is going. And then there's some extra room for extra electrodes. This is the common head box that we use in our EEG lab here. Now let's take an example here. Again, this is the hypothetical scheme of random electrodes placed on the head. Now this is the hypothetical montage. How many channels do you think it has? How many channels? 6. Very good. There's 6 channels. 1, 2, 3, 4, 5, 6. How many chains do you think it has? There's 2 chains. There's 1. There's 2. You see, they're not connected. D is not connected to E, so this is a different chain, okay? What kind of chains are these? Well,
More than,
yeah, the bipolar chains, right? They're bipolar chains because A to B, B to C, C to D, E to F, F to G, so on and so forth, okay? How about this one? How many channels? Still six, right? Okay. How many chains? There's still two chains, right? The first chain is the same, which is a bipolar chain, but this is different. This is a referential chain now because I've connected all of them to one reference, okay? In reality, there is no reference which is totally indifferent. That's impossible because as long as your electrode is somewhere in the head, it'll pick up something. But you pick, for example, if I'm interested in localizing a sleep grapho element, which I know is maximum in the midline, I should probably pick a reference which is distant from it, for example, the ear, so that I get minimum, contamination from that. But in reality, there will be no reference which will be totally quiet. Okay, that's impossible. So there's two chains here, but different than the first one. One is bipolar, one is referential. How about this one? How many channels? You still have six channels. How many chains?
two.
No, one. Look, they're all connected to one reference. So everything that is connected to one reference constitutes as one chain, okay? This is just basic EEG terminology. What is a channel? What is a chain? What is a montage, okay? We'll briefly cover basic EEG technology as to how is a signal acquired and how does it show up on your computer screen. So if you take this simple picture here, again, for simplicity, I'm placing two electrodes. There's wires coming out. The tech is going to place them in this head box or the jack box. And after that, the signal goes through different stages of acquisition before it shows up on your computer screen. The most important stage is this thing called differential amplifier. And you might hear this term over and over if you work in a neurophysiology lab. This is the biggest part of the machine. And I'll explain that in a little bit. But then it goes through different filters. So there's something called a low frequency filter or a high pass filter, and a high frequency filter or a low pass filter. And then because modern EEG is not recorded on paper, it's a digital EEG, you take the analog signal and you convert it into a digital signal. So there's something called digitization. So analog to digital conversion, and then you store it and you record it. So this is the overall pipeline of how the signal is acquired and then it shows up on your computer screen. Now, a differential amplifier, the name is kind of self-explanatory if you think about it. What it does is that it measures the potential difference between the two electrodes that you're recording from. That's the difference, and it amplifies the difference. That's all it does. It amplifies the difference between the two electrodes. So let's say, for example, hypothetically, the electrical potential of this electrode and this electrode is exactly the same. What do you think you're going to see on the EEG? Nothing, zero, because the difference is zero. So when you amplify zero, it's still zero, right? So, but that is what the differential amplifier does. If there is a difference here, if there is an electrical potential difference between two electrodes, it'll detect it and it will amplify it, okay? There's an intrinsic property of the amplifier, which is called gain, which is built into the hardware, how much is going to amplify it. But that's determined by, that's already preset. You don't have to worry about it. So let me show you an example. Let's say this is your differential amplifier, which has a certain gain of G. These are the two inputs, and this is your output. And this is the first input voltage. This is the second input voltage. What do you think the output is going to look like? Well, these slow waves, they look exactly the same. So they're going to cancel out. But then there's this little wave sitting on input 2, which is not there on input 1. So that will be recorded, right? But because it's an input 2, it will flip in polarity because it's in grid 2. So you will see something like this. So this will become flat because the slow waves, the slow potentials are going to get canceled out because they're exactly the same. But this little wave, that is the difference between the two. So that's what's going to be shown, okay? So this is important because there's something called noise in EEG. So EEG electrodes, they're indifferent to our interests. They don't care what we want to record. They will record everything. They will record muscle, movement, noise, and all of those are sources of noise in the EEG. So there's this concept in neurophysiology, what is called signal to noise ratio, okay? So whatever signal you are trying to record, that is a signal of interest, and everything else is noise, okay? So when you're trying to record EEG, EMG artifact is noise, movement is noise, 60 hertz alternating current in your environment is noise. Now, let's say you have these two inputs and there's some source of noise, but it's equal in both electrodes. That is the advantage of differential amplifier because it's going to cancel both of them, even though it's very noisy, you will see nothing, okay? So noise is any unwanted or extraneous signal that you don't want to record. Then there's this intrinsic property of differential amplifier, which is called common mode rejection, which is how good is the amplifier rejecting this common mode extraneous noise. And one of the most common sources of noise that you're going to see is called a 60 hertz interference, which is so the AC current in the United States goes at 60 hertz. If you go to Japan or Europe or India, it's at 50 hertz. So that is a very common source of noise. Anytime you're recording an EEG and there's a source of electricity very close to the patient, in many situations the cell phone, and if it's plugged into the bed or you're in the ICU, for example, and you're recording, there's an ECMO machine or something, it becomes very noisy, okay? So your amplifier will be able to get rid of that to some extent, but not, completely. They have limitations. If I were to show you this graph of, relative amplitudes of various signals compared to EEG, look where EEG is. Literally everything else is bigger than EEG, okay? EKG is bigger, EMG is bigger, electrical noise is bigger. The only things that are smaller than EEG are the things that you're not going to record. They're evoked potentials, which are not going to be given. So that is why you have all these stages of acquisition to get rid of the noise and to filter out the signal to put it in the range of interest, the thing that you want to record. Now, physiological EEG rhythms, as you record them on scalp, are usually between 0.5 or 1 hertz to 70 hertz. That is the range. So that is why filters are set up like that. So even if there's going to be more noisy signal, because you're going to filter the noise out, you try to get the signal acquired in this bandwidth, okay? So there's two filters, which are gonna be on the machine, which very commonly people play with. One is called a low frequency filter. So think about it like this. So this is your bandwidth, okay? Low frequency filter is on the lower end. It's going to block everything lower than this frequency from coming in, okay? So for example, let's say this is this hypothetical waveform here, which is a slow signal, and my low frequency filter is set up higher than this, so it's going to attenuate it significantly, okay? But if I send a frequency which is faster than that, it's going to let it through unimpeded. It's not going to touch it, okay? Now, on the other end of the spectrum, you're going to have the high frequency filter, which is going to cut off everything faster than your highest frequency of interest. So here, if you send this very, very high frequency signal, it's going to attenuate it significantly. But if you send something slower, it'll let it through, okay? So you can imagine how these two filters are going to create your bandwidth of interest. So below 1 hertz and 70 hertz, and under 70 hertz. Then there is this unique filter, which is going to be built into every machine that you're going to be working with, which is called a notch filter, also called an AC filter. This is specifically put in there to get rid of the 60 hertz noise or the 50 hertz noise, depending on where you are. Now, this is a unique filter because it will only selectively get rid of signals which are around this frequency. So it doesn't affect the rest of the bandwidth that you're just recording, it'll just get rid of this. And after you have processed the signal through the differential amplifier, the filters, you have the analog signals. Since we're not recording on paper, then you have to digitize the EEG, okay? This phenomenon is called digitization. Essentially what you do is, I'll show you an example here. Let's say this is the analog signal that you are going to record, okay? What you're going to do is imagine this entire analog waveform made up of individual voltage points, these dotted things, okay? If I'm not sampling fast enough, let's say I'm sampling only these points. When I digitize a signal, the waveform is going to look like this. It's going to be connected to these voltage points. So this waveform is nowhere close to the original waveform, okay? So this is called aliasing. So there is also an anti-aliasing filter built into the machine. So essentially, you don't want to do this, which means you want to sample at a fast enough rate, okay? And that is called the Nyquist frequency, okay? So now I just told you the highest frequency of interest on EEG physiologically is a 70 hertz signal. So your sampling rate should be more than twice of that, not twice, more than twice. So it should be more than 140 hertz, okay? So this is called the Shannon-Nyquist theorem. This determines what the sampling rate is when you digitize a signal. And I'll show you standard settings later, but the minimum sampling rate that most machines will have is 200 hertz. If you're sampling under 150, you're not going to see signals above 70 hertz or around 70 hertz. You're going to get cancer. You're going to get illness. Okay. So this is the standard scalp EEG settings, which we have in the labs and most normal machines have. So the high frequency filter is set at 70 hertz, so it blocks everything above 70 hertz. Low frequency filter is set at 1 hertz, so it prevents anything below 1 hertz from coming in. Then you have the notch filter, which is optional. You can turn it on, turn it off, okay? And the sampling rate is at least 200 hertz, okay? To give you an example, when we record intracranial EEG, the highest frequency of interest is almost 600 hertz. So obviously the sampling rate is much higher. So with intracranial EEG, sampling rate is 2000 hertz. So now you might ask, okay, why don't we just sample at high speed for everything to get a high quality data? And that has to do with storage. The higher your sampling rate, the more voltage points you're going to store. You're going to run out of server space really fast, whatever lab you're working in. So that's why every lab, sleep lab or neurophysiology lab, they have to have this thing where the techs have to clip the recordings, particularly longer recordings. Now, when you start reading EEGs or, in your case, sleep studies with EEGs, my recommendation is to not alter filter settings to make your signal look better. Particularly a lot of people, what they do is that if the signal is a little noisy with muscle, they drop the high frequency filter. That significantly affects the quality of the signal. And you might start seeing things which look like epileptiform spikes, but they're not epileptiform spikes. So you have to be very careful. If you're going to do that, you have to be ultra conservative in calling something epileptiform because you might be wrong. Because a lot of things, when you apply the high frequency filter, it applies to everything. It applies to muscle, it applies to EEG. So a lot of waveforms, if you apply a high frequency filter to a lot of EMG signal, it will look like EEG. And it might look like a pathological waveform, and it isn't. So you have to be careful. So if somebody has done that, make sure you reset the filter back. This is a digital EEG, you can play with the filters all you want. Now, let's say you're in a situation where you know that the waveform of interest is a slow wave that you're interested in seeing, then you can apply the high frequency filter. It's not going to affect your scope. Okay. I'm going to show you a few montages. These are the standard montages we use in the lab here. We have 6 standard scalp montages. I'm going to show you, I think, 4. This is the one that people everywhere in the world use. This is called the longitudinal bipolar montage. People also call it a double banana. It looks like 2 bananas on your head. Okay, as you can see, it's a bipolar montage. It has 5 bipolar chains. There's a left temporal chain, which is this one, which goes from FP1 to O1. Then there's a right temporal chain, which goes from FP2 to O2. There's a left parasagittal chain, this one, right parasagittal chain, and this midline central chain. They're all bipolar chains. It has 5 chains. This is a very commonly used montage all over the world. In the United States, we place it like this on the EEG. You have left temporal, left parasagittal, right parasagittal, midline. In Europe, they usually place left temporal, left parasagittal, then they place the midline, and then they go to the right side. Okay, it's just convention. This is also a very commonly used one. This is a referential montage connected to each ear as a reference. A1 and A2. A1 is the left ear, A2 is the right ear. How many chains are here? 2. Because you have these connected to A1, these connected to A1. This is one referential chain because they're all connected to A1. And then you have this connected to A2, A2, A2. This is 2. So you have 2 referential chains. Okay. So chain number 1 is all connected to A1. This becomes very important. You probably are not going to be reading 16 or 18 channel EEGs, but it becomes important if you're trying to localize an EEG potential. You need to know what chain you're looking at. And this is the second one. This is also a very commonly used montage where everything is connected to CZ, which is a midline electrode here. This is probably not good when you're recording sleep potentials because you will see it in every single channel because it's coming from CZ. A lot of sleep grapho elements are localized to CZ. So if you connect everything to CZ, you're going to see it reflected in every channel. So it'll look like it's everywhere, but it's really not. It's just coming from CZ. This montage, as you can see, only has 1 channel because everything is connected to CZ. Okay. I'm going to skip these ones for now. Now, just the basic scalp EEG frequencies. There are predominantly 5 frequencies that you're going to hear about over and over. There's delta, theta, alpha, beta, and gamma. Delta is a slower one, which is usually 1 to 4 hertz. Some people would say 1 to 3 hertz. Theta is 5 to 7 or 4 to 7, depending on who you ask. Alpha is 8 to 13 hertz, beta is 13 to 30, and gamma is more than 30. The one that I'm gonna show you an example of, I'll show you others as well, is the alpha rhythm, which everybody will talk about. Alpha rhythm is in normal awake adults, this is the predominant EEG background, okay? This is, as you can see, it's a longitudinal bipolar montage here. You see this rhythmical activity, these two dark lines are 1 second. If you count this is probably 8 to 10 hertz, okay? So a normal awake adult, when their eyes are closed or they're relaxed, their predominant EEG background rhythm is an alpha range and it's predominantly maximum in the back. So you will hear this terminology called PDR, posterior dominant rhythm, because it's maximum in the posterior derivations. It seems to be generated in the visual cortex and visual association cortex, okay? Now, as a sleep neuro, start. As you can see, this person, they close their eye here, and then this posterior dominant rhythm comes out. One of the ways to bring it out in EEG labs is to ask the patient to close their eyes, okay? This is not something you see in sleep. In sleep, you see the other waves, the slower waves, predominantly delta and theta. And I'll show you some examples of them. The other thing which I think you should be aware about are common artifacts that you're gonna see on recordings. Now, you might not see the whole spectrum of this, but I'll show you a few. This is a very common example. Uh, Obviously, you're gonna be seeing more sleep, but you know, as a person goes from wakefulness to sleep, this is a very common biological artifact that you're gonna see. This is an eye blink artifact, okay? So the eye, human eye is electrically charged. It's actually an electrical dipole. Front is more positive than the back, and it creates this very characteristic artifact, which, as you can imagine, this would be maximum at FP1 and FP2 electrodes because they're the closest to the eye, right? So it looks like this. So the electrical field created in the eye blink artifact is maximum at FP1 and FP2. It looks like this big downward deflection in all the channels that are connected to FP1 and FP2. It's a very common source of artifact. The other common source you're going to see, you see this dark stuff here? This is muscle, okay? It's very commonly going to be present throughout. This is the other common source of artifact, which you may or may not see. This is produced by horizontal or lateral eye movements. Again, looks like big upward or downward deflections connected to FP1 and F7. This page has an artifact. Can you guys guess what artifact we see here? You see the stuff that comes periodically like this? Can you see it? What do you think that is? Look at channel number 20. Yeah, that's the EKG artifact. Okay. It's also a very common source of artifact. Again, same concept. Your heart is not in your head, but it's just the volume conduction of the electrical potential generated by the heart. Now, the two electrodes in the EEG, which most strongly pick up EKG artifact, are the ear electrodes because they're physically lower, so they're closer to the heart. Okay, this is the ear reference montage connected to A1 and A2, and A1 seems to be picking up a lot of EKG. Okay, the EKG vector has a very specific orientation on the head. If this is the left, the right, front, the back, EKG vector is oriented in an oblique manner across the scalp like this, which determines its distribution. You have a large positivity in A1 and a large negativity in A2. This is just the polarity of the QR spectrum on the head. Now, this is something which you will obviously see a lot. And the reason I'm showing you some examples here, because this is something that gets overcalled a lot as epileptiform. So one of the things you must familiarize yourself with while reading sleep-related studies are normal variants, sleep-related normal variants, which look epileptiform but are not. And one of the most common one is this. This is called a wicked spike, okay? it looks like this. It looks like this spiky waveform, which is rhythmical, and it's usually maximum in the mid-temporal area. Okay, so you will see it in the temporal chains if you have placed them. It's usually 6 to 11 hertz. It has this pointy characteristic, and it's usually seen in the transition state between wakefulness and sleep, but it can be seen in stage 1 sleep, and it can be unilateral, it can be bilateral, but the important thing to remember is it is a normal variant. It should not be classified as, for example, I've seen this many times, it gets classified as temporal lobe epilepsy, but it is not. It's a normal variant. So one of the things in EEG is to familiarize yourself with normal variants and artifacts to prevent overcall of things. Now, there's another variant which is very common and gets overcalled a lot, which is called RMTT, rhythmic mid-temporal theta. It is this rhythmical theta activity, also maximum, in the temporal derivation. I think about this as an extension of the wicked spikes. It looks nearly the same area, it's just long, okay? This is also something that gets frequently classified as pathological temporal lobe slowing. And a lot of people think this is indicative of an underlying structural pathology of the temporal lobe or temporal lobe epilepsy. Both of them get overcalled a lot. This, as opposed to wicked spikes, is usually in the theta range, as you can see, 5 to 6 hertz. So a lot of times also called theta range. That's why the term theta isn't there. Again, this tends to occur mostly in the transition state between wakefulness and sleep or in stage 1 sleep. But it's temporary and it goes away. It can be unilateral, it can be bilateral. The important thing to remember is to not overcall it as pathological unless you see it persistently there all the time through all the stages of sleep or during wakefulness. All of these variants tend to be more common in younger patients for some reason. Brain gets boring as you go. This is also something, this is not very common, it's rare. It's called frontal arousal rhythm. As the name indicates, it's usually seen as a patient is being aroused from sleep. It is maximum in, as opposed to the temporal region, as you can see, this is maximum in the frontal region, in the paracellular derivation. It usually has the spindle-like shape, 7 to 10 hertz. Again, mostly seen in children and young adults. It's not very common, but if you see it again, remember it's not pathological, it's a normal variant. This is one of the ones that gets overcalled a lot and is extremely common. I've seen basically almost every other patient has it. It's called hypnagogic or hypnopompic hypersynchrony. As the patient goes from wakefulness to sleep or sleep to wakefulness, right before they either wake up completely or go to sleep, there is this synchronous burst of large amplitude delta waves, like here. Again, totally normal. It's a totally normal variant. It's very slow rhythm. It's delta range, so 2 hertz, 3 hertz, very large in amplitude. It looks scary, but it's not. It's totally normal, particularly when it occurs at this transition stage. So as you see, one of the things here is a lot of this stuff occurs at the transition stage, right as the patient is falling asleep. So it's good to know this. Then this very common, which you will see a lot as well, it's called POSTS, stands for posterior occipital sharp transients of sleep. This is mostly seen in stage 1 sleep. As you can see, these are these upward deflections when your O1 and O2 are in grid 2. So this is the positivity at O1 and O2 because it's an upward deflection. So these are seen in stage 1 sleep. Okay, these are these upward deflections in this longitudinal bipolar montage, very commonly seen in sleep, very common, especially in younger patients. Also, these are not pathological. Okay, and I'm going to show you a few pictures of different stages of sleep. I'm sure you're going to learn about this in much more detail. But stage 1, non-REM sleep, the typical EEG appearance, this is probably more extensive than what you might see, but essentially some of the key characteristics are here. The PDR or the alpha rhythm will disappear or will become more interrupted or become more attenuated or will slow down. If the alpha rhythm when the person was awake was 10 hertz, you might see a 7 hertz rhythm, or you might see it completely disappeared. The other thing, you will see these very slow waves, maximum at the frontal polar electrodes like this. You see this? How slow this wave is? This is 1 second, by the way. These are created by roving eye movements. As the person becomes drowsy, they have these roving eye movements. They create this very slow artifact, which is maximum at FP1 and FP2 again, because again, it's created by eye movements. You can see the posts, and you might see a little bit of underlying delta waves coming in, okay? But stage 2 is when you actually start seeing the typical graph elements that we all learn about. You start seeing V waves, which are these kinds of waves, which are maximum in the midline electrodes. V waves have a very peculiar distribution. They are maximum negative at CZ. CZ is usually the maximum negativity. So if you look at this way, for example, here, you see FZ to CZ is a downward deflection and CZ to PC is an upward deflection. It's called a negative phase reversal. CZ is the highest negativity. This is a very typical distribution of a B wave, also called a vertex wave. Also important to know this because this looks very spiky, looks very sharp, but it is not epileptiform. It's a totally normal variant. Unless you see it during wakefulness, that might indicate something else. But as long as you see it in sleep, it's normal. The other thing which you will see, you'll see a lot, is a K complex. This is a bit of an example of that. K complex is a very large wave. It goes on for about 1 second. It's polyphasic or biphasic. You will see nearly in all the channels connected to the EEG, and it's usually flanked by this spindle rhythmical activity. And I'll show you another example here. You see this big wave coming in, maximum you see throughout, very large, going on for more than a second. And then you have this rhythmical activity, which is a spindle, okay? Sleep spindles and K complexes are typical grapho elements, characteristic of stage 2 sleep. K complexes can be seen in deeper sleep as well, but not the spindles. Spindles have a very peculiar frequency. They are usually between 11 to 14 hertz. So they overlap with the alpha band a little bit, okay? I'm not going to show you deep sleep because I couldn't find a sample in my list, but it's a lot of delta sleep. It's a very slow EEG. This is REM sleep. I find REM sleep fascinating. Whenever I see it, I get very excited. Because we don't see it a lot. All of our patients are sick and they never have REM sleep. So whenever I see it, I get very excited. REM sleep is very bizarre. The way I identify REM sleep is by this. These are, this is eye movement artifact. These are saccades. As you know, REM sleep obviously has saccades in multiple directions. These are saccades. As you can see, they have a deflection here and here, corresponding deflection in both temporal chains. Brain waves cannot do that. Okay, these are horizontal, oblique, or vertical saccades. When you see back-to-back saccades, but the EEG does not look like the EEG of an awake person. There is no alpha rhythm. There is mixed delta, theta frequency. There might be some faster frequencies. This is REM sleep. Okay. Sometimes they have these things called sawtooth waves. I could not find an example, but they're basically like sawtooth, mostly maximum in the midline electrodes. One of the common scenarios where I see this being pathological is obviously I don't do multiple sleep latency tests, but when a patient comes into the neurophysiology lab for a routine EEG, obviously the person is awake. If they go into REM sleep during the routine recording 23 minutes, it's pathological in most cases. Now, it doesn't necessarily mean they're narcolepsy. They could be just sleep deprived or could be, so that's one of the findings we often write in our reports if we see that. What's called sleep onset REM. Okay, so that was a whirlwind tour, basics of EEG. There's a few points I want you to remember. Remember, EEG is recorded with a minimum of 2 electrodes. You cannot record EEG from 1 electrode. You have to have 2 electrodes. You cannot record absolute electrical potential. You will always record an electrical potential difference. Remember the polarity convention. Waves are not positive or negative. Waves are deflections up or down. Electrodes are positive or negative depending upon which electrode you're referring to. The other thing you should familiarize yourself with, and I strongly recommend this, familiarize yourself with all the normal sleep graph elements and all these normal variants, because the last thing you want to do is be overcalling these elements as epileptiform. And then the other thing you probably should learn about a little bit are the common sources of artifact in EEG, so that you won't overcall those as well. And that's all I have.
Thank you. Do you guys have any questions, or I don't know how much time you have left here?